Thanks, Jeff, and thanks once again to Innovasis to let me participate in this great meeting. And good morning, everybody. Hopefully people weren't out too late last night. So let's get started here, just in terms of background, and Jeff just alluded to this. I mean, this is such a humbling thing, and no one has this solved. When I see this on an x-ray and someone comes in with back pain, you know, the first thing you do is curse. And it's just like, God damn. And, you know, that's just the response that you have. Sorry, but it's demoralizing, it's humbling. You know, you're going back, what did I do wrong? You know, can you blame it on somebody? It's costly. It's the fellow, it's the resident, it's the patient. You know, did you jump out of bed? And so it certainly makes us look back and be reflective of how we can doing our job better. And just to remind everyone in terms of the definition, it's greater than 10 degrees of kyphosis from the UIV to 2 levels above the UIV, and at least 10 degrees greater when compared to pre-op. And remember, junctional kyphosis is really just one type of adjacent segment pathology. A neurologic injury is rare, although Jeff describes that horrible case of paraplegia. It's generally quite rare. And it's a stress concentration mechanism. You have a long, stiff segment and right adjacent to a very flexible segment. Type 1 is basically fracture, failure of the bone. Type 2 is pull out, failure of the instrumentation. These are all my cases, unfortunately. And there's plowing of the top instrumentation. And then the type 3 is sort of a soft tissue or osteoligamentous failure. This is a patient who came to me horseback riding after his long segment fusion with a massive disc herniation. So there's all different types. We're going to focus mostly on the fracture type. There's all these risk factors. So maybe someday we're going to be doing a risk factor analysis, plugging in all of these different things for our patients to figure out who we should and shouldn't operate on. Osteoporosis is an easy one for us to identify and hopefully control. Obesity is another one. Number of levels of fuse, I think we're all trying to grapple with this. Distance from the most kyphotic segment to T1, plumb line. Type of implants, we'll talk about some of this, anterior posterior surgery, the type of pelvic retroversion, types of osteotomies, pelvic parameters. These are all important things for us to figure out. And frailty is certainly a big one, and we're learning more about that as time goes by. Frailty is real. The general surgeons, I think, are ahead of us a little bit in terms of frailty. And remember how expensive revision surgery is. Payers and systems are clamping down. We had a surgeon in our system who is having high complications with multi-level fusions. He was actually asked to leave the system, and now he's doing non-operative spine care. BMI might become an easy denial. BMP might become an easy denial too. And be cautious of the patient that comes into your office and says, "Oh, doctor, I'm so glad you're here because you are my last hope." Like when someone says that to me, I'm like, oh no. I'm like, you definitely don't need surgery. And then what about the question of spinal cord stimulators? There is gradual emerging evidence for failed back that maybe stimulators are a better answer for us. And I think we need to think about alternative technologies in patients that have chronic pain and we don't have an easy solution for them. Optimization of bone density. I think it's key here. We have an opportunity to engage our endocrinologists. Thankfully, at our hospital, we have a great endocrine team. They love getting involved in these, or kind of asking us if they can be more involved. The best research is on PTH analog. It improves bone mineral density at the UIV +1. It can reduce the risk of proximal junctional kyphosis. So this is something to really seriously consider. Education, I think this is huge as well. Not only figuring out if there are certain things that are putting patients at risk, like do they have bad hip arthritis and a hip flexion contracture, just have them get their hip done. Or do they have knee arthritis, knee flexion contracture? I had one patient who had a total knee, had a really contracted knee, and he went in for revision surgery prior to his PSO and made a big difference in his lumbopelvic mechanics. What about vaulting and slumping? So patients after a long segment fusion, just to get out of a chair, will often vault to get out of the chair, and it induces a huge flexion moment right at their junction. Same thing with the opposite. As they're trying to get into a deep seat, they'll just slump into a seat, and it'll create an axial compression load on their junction. So I talk to patients about that before their surgery, and our therapists do as well as after surgery. What about bracing? Can you brace them on their sternum and kind of keep their chest above their pelvis? Thought about taping. I've never done this, but whether or not taping is a reminder, physio taping, it'd be a simple, non-invasive way to just remind patients to keep their torso upright. And we talked about the contracture piece. Losing weight. One of my mentors said, look to a patient, you have to get yourself to the starting line. I'll help you finish the race, but you got to get to the starting line. And that's where if a motivated patient knows about that, you can tell them where their BMI threshold is and tell them the amount of weight they need to lose and the time they need to lose it. Optimizing nutrition, we talked a little bit about this yesterday, looking at total protein, albumin, prealbumin, making sure their protein stores are high, strengthening their core. We offer patients a prehab program. That's partly educational, but part of it is just to get them strong prior to surgery. Consider short segment surgery. This is a 65-year-old, very active patient, does yoga, Pilates, still likes to go to the gym every day. She had a single level stenotic segment at 4.5. It's really below the apex of her scoliosis. And we just did a simple decompression. And she's out of the hospital overnight and is really happy she's 3 months out and functioning at a high level. We have to age adjust our correction. In the sagittal plane, T1 to pelvic angle increases over time. Our pelvic tilt increases over time. Our SVA increases over time. Our PI to lumbar lordosis increases over time. And so we just have to adjust those parameters. And Frank Schwab, I'll go back for a second. Frank Schwab in that second study listed there showed that for patients that were overcorrected, they increased almost linearly, they increased their risk for proximal junctional kyphosis. So we don't want to bring a 75-year-old back to straight onto the pelvis. What about soft tissue handling? I really try to do my best in preserving the upper muscular envelope, including the neuromuscular innervation. So looking at the facet innervation, preserving the dorsal rami, preserving the capsules and the ligaments proximally. Consider MIS at the top, burying your instrumentation. What about the importance of the soft tissues beyond just what you're doing in terms of protecting the musculature? This was a sheep study. They instrumented T2 to T7, and they compared sequential destruction, a ligament resection versus facet capsule resection. You can see here when they applied flexion moments, statistically increased risk of proximal junctional angle with further destruction of the soft tissues. And this is a study that we did just very recently. It was funded by Innovasis to really ask the question, how important is the muscular envelope and the various soft tissues in controlling the proximal junctional segments? And so we did a sequential destabilization where we cut skin, cut muscle, cut fascia, and then did laminectomies and followed that with sequential closure and then even closure to a prosthetic lamina. So one of the engineers, Anthony Ruggiero, had the thought, well, what if we just attach a fin to a crosslink and get this as a 510? And that could serve as a prosthetic lamina, and then you can suture right through that. And so that's what we did after a laminectomy, multi-level laminectomy, and then you could close sequentially to this prosthetic. And then we looked at sequential range of motion at the proximal adjacent segments through the middle of the construct and the distal adjacent segments. And I'm not going to go through all of this, but if you look at the right side, the blue bars, as far as flexion moment, the blue bars are for flexion extension. Following laminectomy, and then looking to the right, we close the laminectomy, and then we close the muscle, fascia, and skin to the prosthesis. And you can see that stiffening that happens, the decline in motion. And then the final is the denuded, so typical treatment where you remove all the soft tissues and dramatic increase in range of motion with loss of the soft tissues. So just a pilot study, and hopefully we'll follow this up with some more detailed analysis. What about ligament augmentation? The Ames group showed in a clinical case series 100 controls versus ligament reconstruction at the UIV, UIV plus 1 and UIV minus 1. And ligament augmentation certainly reduces clinically the risk of PJK from 14 degrees in the control to 6 degrees in the ligament augmentation group. And implant selection. Pat Cahill showed in a finite element analysis that if you use a transition rod at the proximal segment, you restore normal pathomechanics. And what about other metals? What about using titanium, a softer metal, versus cobalt chrome? And my mentor, John Kostwick, used to always say, use big screws but small rods in adult deformity. And so titanium rods, but really sound pedicle fixation. And then what about non-fusion alternatives? These really are not FDA approved as a non-fusion device. They have been used. I've used these on selected cases. I really haven't been happy over the long haul. They tend to break over the long haul. Jeff mentioned the transverse process hook versus screws at the UIV, and this was a study that compared hook versus screws. And the hook group was interesting. The hook group and the screw group had no statistically different numbers of proximal junctional kyphosis, but their junctional angle was different. So the hook group only had 5 degrees at the junctional angle, but the screw group had 19 degrees. So their conclusion was that hooks can reduce the severity of the deformity, although they may not change the absolute incidence of the deformity. And then polyethylene tethers, again, tethering the spinous processes, another study. I thought this was pretty dramatic. If you look at the tether tied to a cross link, the incidence of PJK was around 18% compared to 45% for no tether. And any of the tethers, either a tether alone or tether connected to a cross link, statistically significantly different than no tether. And then cement augmentation. I think a lot of us in the audience probably have done this or have tried this. This is a retrospective case control series, 47 control, 38 cement patients, and with 2-year follow-up, and statistically significant improvement if you use cement at the upper levels, with really no different sagittal plane and other parameters. The PMA patients had more degree of osteoporosis. So in conclusion, clearly we have to individualize our care. We have to get our patients to the starting line, protect the neuromuscular envelope, whether this is open or MIS techniques, and consider some of these novel or emerging implants. Thank you.